This conference will now be recorded.
All right, we're going to get started. Welcome to this edition of EMS Journal Club, November 11th, 2020. Happy Veterans Day to everyone. And we have Greg presenting and run the conference today. Greg, are you ready?
Yeah, I'm ready. Can everybody hear me all right? Hear me good?
Yeah, we can hear you.
Yep.
All right, perfect. Well, good afternoon, everybody. Thank you again for joining us on our monthly journal club. Today we have a special guest appearance from the EM residency at North Beth Israel, who were graciously enough to join us today. Thank you for you guys for all showing up. So today we have a good lineup. We have a lot of articles to kind of get through, just about 3 or 4 very interesting topics that pertain to both kind of the EM and EMS settings. So I'm going to be starting also today, like I said, there's going to be 3 of us presenting. Myself, for those of you that don't know me, Dr. Greg Dorlis, I'm MD 480. If you guys ever get orders from me, we have a Dr. Corey, who's MD 485. And we have Dr. Rubin, who's currently MD 425. She's one of our pediatric EM fellows, who's going to be presenting with us today. All right, so kind of moving along to the first paper here, sorry. And then we have moderating, we have Dr. Nalin, who's here, Dr. Tagore, and Dr. Steenberg as well. All right, so moving on to the first article that we're going to talk about. The clinical question here is, in cardiac arrest, does the use of esmolol in patients with refractory VFib or pulseless VTAC who achieve ROS, does it improve your hospital survival to discharge and improve your cognitive function to standard of care? So this is the paper that we're going to be going over in detail. Excuse me. So what is the mechanism? So I kind of tried to find a cool background of describing the electrical storm. That's what some people is referred to refractory VFib. What we kind of see the mechanism behind it is that there's a huge increase in your sympathetic tone. A lot of it is sort to believe is due to epinephrine, specifically the repeated dose of epinephrine, as we all know that is given during cardiac arrest. And we know we are using the epinephrine because it works by primarily improving the coronary flow. But we all know as a whole that epinephrine it does come with its side effects, such as it increased the myocardial oxygen demand, definitely some demand on the myocardial ischemia, and it also depresses the VF threshold. So part of this paper is talking about the use of esmolol. So why esmolol? So esmolol is one of the fastest onset and shortest half-life of any beta blockers that we know. Per the literature, it's saying about quick on and off of about 9 minutes. And so what esmolol is thought to do, it helps to kind of help with the catecholamine surge that's increasing the threshold of defibrillation. So, here is the epinephrine chart here that I found, a cool table that kind of goes into detail about epinephrine adverse side effects. So as you can see here, it's got the myocardial dysfunction, arrhythmias, increased O2 consumption, calcium overload, right to left shunt, and the formation of kind of radical oxygen species. Moving on, so beta blockers, the mechanism of beta blockers that most of us are familiar with, it helps with the decrease of the O2 demand, stabilizes the myocardium, inhibit calcium influx, inhibits hyperphosphorylation, which is also one of the mechanisms behind this, using your RI2 receptors, and it's also antiarrhythmic. All right, so kind of going through our checklist here for the PICO question. So PICO, the first thing that stands for is the P, the population, so the inclusion criteria. So the patients, obviously, whose initial rhythm was VFib or pulseless VTAC. The setting of this article is in cardiac arrest in the ED or had cardiac arrest pre-hospital and remained in arrest upon the ED arrival. The patients that received greater or 3 defibrillation attempts that also received the full dose of amio 300 milligrams and at least 3 rounds of epi, so 3 milligrams of epinephrine total. And the last one is patients that receive esmolol following ROS were included, but in a no esmolol group. And the exclusion criteria primarily were patients that received esmolol prior to the cardiac arrest. So the intervention. So the dose of the esmolol that they used here was esmolol 500 mics per kilogram as the IV loading dose. And then in some cases, they would start an infusion at 0 to 100 mics per kilogram per minute. With kind of comparison to the traditional protocol, which is just kind of continuous defibrillations and the use of antiarrhythmics, usual standard of care. So the outcomes. So the primary outcome that we were trying to, this paper was trying to look at was the success of reaching ROS. So were you able to achieve ROS? In this one, they used temporary ROS, and they clearly defined it, which I really like. They wrote lasting more than 30 seconds, but less than 20 minutes. Then they have another outcome where it's achieved sustained ROS, which is greater than 20 minutes. And then they use time that it took for you to achieve ROS following the administration of ESMOL. And then there's a whole bunch of secondary outcomes here. So if we're kind of looking at this table here, if you're looking at the achieve ROS, temporary ROS, so in the ESMOL group, there's only 6, a total of 6. And then in the no ESMOL group, there's a total of 19. So in the temporary ROS, 4 out of the 6% were able to get, temporary ROS for more than 30 seconds, but greater than, less than 20 minutes, and the same kind of in the sustained group. Then a whole bunch of the secondary outcomes were here are patients, once they got ROS, some were found to have a STEMI, some had to be taken in cath lab emergently. Those that did survive, did they survive to ICU admission? And we're kind of looking, I don't know if you guys see my mouse pointer, but on that left-hand column, the ESMOL group, we're looking at the survival to ICU admission percentage. So 4 out of the 6, they made it to therapeutic hyperthermia. Survival to hospital discharge was about only 50% of them. And then survival to discharge with good neurological outcome, which we will touch upon after. So moving on, so the author's conclusion. So in patients following failure of standard of care who present in VFib or pulsus vitae, they may benefit from beta blockade. Potential harm that was unclear. They recommend more prospective studies of the beta blockade in cardiac arrest is warranted, and blockade should be considered in patients with refractory VFib resistant to standard therapy prior to just prior to you kind of stopping your resuscitative efforts. So kind of going through the checklist for this kind of study, observational study. So did the study address a clearly focused issue? I wrote down yes. I mean, they identified a problem that we've all seen out in the field or have at least had to address while giving medical direction to the medics. I'm pretty sure when we pick up those phones or we've been out there pre-hospital, we've seen this happen. I've seen this happen multiple times. So I think this study did address a clearly focused issue. Did the authors use an appropriate method to answer their question? Yes. They did a retrospective review over the past 3 years at a big urban institution into patients that fell into the category of the refractory VFib that were treated conventionally versus with beta blockers. I do believe the cohort was recruited in an acceptable way. The outcome was accurately measured to minimize bias. This next question, the confounding factors, did the author identify some? So in the next kind of graphics and figures that I have on the next previous slides, I'm going to show you one of the big confounding factors here was the adjunctive medications that were given. We'll touch upon that after. The other difference too was in EMS providers. So one of the things the author said is that, they are at a big urban tertiary center, so they work with several different agencies. So the training amongst, BLS and ALS, they're obviously, I mean, they could be different if you're not with the same system. So the practice and the scope, I mean, everyone runs cardiac arrest pretty much the same, but they were saying that, the quality of chest compressions, kind of definitely played into this. Placement of pads to change the vectors during the defibrillations. There's a whole bunch of things that kind of were confounded that, we really couldn't take into account. Next question was the follow-up for subjects completely enough? Yeah, they followed the patients who actually had a ROS and made it to the hospital. They followed them up to discharge. How precise were the results? I think they were precise to the best of their ability. Do I believe the results personally? I've been on, I've taken medical direction calls for these cases, not often, but, a couple times throughout my residency and now as a fellow. And, I know that our medics specifically don't have esmols to kind of administer, and I've been kind of going with the metoprolol 5 milligrams IV. And, I have seen it work where they get ROS. I'm never really followed up to find out what happened to the outcome of the patient, but I have seen it work in some instances where they do get ROS and sometimes where it's just persistent and nothing happens and we eventually have to call it. Do I think these results can be applied to a local population? Um, I do believe so. Possibly not. It just depends on the state and their and kind of protocols and the availability of ESMAL. The reason why we like ESMAL is because, like I said, there's a quick on and off compared to other beta blockers. I'd definitely like to see a study done where they use, one of the more common beta blockers like we have available, metoprolol. There was some other study that I read where they used atenolol. So I think definitely more trials need to kind of be done to kind of observe these things. Um, Moving on. So here are the key tables and figures that I was talking about. So table one, so we like to use this table one just to kind of look at our baseline characteristics to see the demographics of the patients in both groups. So here we definitely see that there's an uneven amount of patients in each group. There's only 6 in the ESMAL group and only 19 in the no ESMAL group. The ages are about similar. The gender in the ESMAL group, they were all male. And in the no ESMAL group, the majority were all male except one female is there. The initial rhythm was VFib, more so in the ESMAL group. Witnessed cardiac arrest. So in the ESMAL group, we know that early CPR leads to a better outcome. So in 5 out of the 6, it was witnessed cardiac arrest. Bystander CPR was started in 3 out of the 4 cases, and in 14 out of 18 on the no ESMAL group, which is very important. And kind of looking from the time from the call to EMS arrival until when they got to the hospital. The next table, so kind of going through, I want to show you guys the intervention table. So I like this table here a lot because it actually shows you in detail the 6 patients in the ESMAL group. So what I want you to pay attention to is a couple of things. So the second column here, defibrillation attempts prior to ESMAL. So if you look at patient 1, they got shocked 10 times, defibrillated 10 times prior to ESMAL. So look at these numbers. Patient 6 got defibrillated 13 times prior to getting administration of ESMAL. And when you're kind of looking at it, seeing the dosages and the medications, so this column here, the next important one, was the medications administered after ESMAL. So if you look at the graphics here, I know they're listed in numbers. So 1, if you see the number 1 here, was sodium bicarb, 2 was adrenaline, 3 was atropine, 4 was calcium chloride, 5 was lidocaine, 6 was potassium, 7 was vasopressin, 8 was levodopa, norepinephrine. So these kind of come into the whole confounding factors that the author kind of alluded to in the paper, because did the ESMAL really do the trick, or was it because the patient also received these medications and adjunctive to the ESMAL? And also, we all know before, for part of the inclusion criteria for the patients here, they had to receive already the standard of care of medication, which was 300 milligrams of amio and at least 3 doses of epinephrine. So then the next important column here is looking at the fibrillation attempts after ESMAL was given. So patient 1, who already received 10 defibrillations prior to ESMAL, got another 9 after the ESMAL. And then I think that one is the only one that was kind of outstanding, that was kind of standing out compared to the other ones. As you go down the list, they receive less and less shocks. And then those who sustained ROS obviously after the ESMAL was the 4 out of 6. Surprisingly, patient 1 was one of them, and patient 6, those who got the more defibrillations on an initial arrival. So that was very important to kind of highlight. So next part of this is kind of an additional article that I also wanted to talk about that kind of highlights what were the same themes. So this was a systematic review of the use of beta blockers for treatment of cardiac arrest due to VFib and pulsus VTAC. This one was conducted a little earlier. The prior paper was in 2014. This one was like in 2011. But this paper is interesting because, so the key points here, they found, it was conducted, I think, in Brazil. So the studies, they looked through the Medline databases. They searched clinical trials, case reports, case series, experimental studies, as termed that follows with tachycardia, VTAC or VFib, or resuscitation. Then they broke it down even further to use keywords such as beta blockers, where beta blockers were used in the case. So only those type of articles were the ones that were pulled. And so what's interestingly enough, what they came out with at the end, they had 24 studies. So 12 of the studies were animal studies, 10 were case reports, and 2 were human clinical papers that were analyzed. So again, this is kind of how they broke it down. They looked through the database. They had over 1,000, hits with that one. But once they broke it down even further and went through the exclusion criteria, so they simplified it down to 24, studies that they were able to focus on. So here they kind of outline most of the studies, and kind of I know there's a lot of stuff going on here on this slide, but what I want you to pay attention to is that table 1. So this is your animal studies. So all these studies here were conducted on animals. So dogs, rats, and pigs. So here, this is kind of where I was alluding to before, where they use different beta blockers in the prior study. So here they're using propanolol. They're also using epi with esmolol, phenylephrine, and esmolol. I think in one of the other studies we're using atenolol. But if you're looking at the results here, you're looking at the rates of ROS whenever a beta blocker is introduced. There is definitely a higher success rate versus placebo alone, or compressions, or just the standard of therapy, standard of care that we are usual to do. So beta blockers, we have noticed, have been making a difference as early as 2011. I'm sure earlier than that when they conducted these studies. So they did see a difference. The next slide, again, kind of going into rats, piglets, using esmolol plus placebo, carvedilol and epinephrine, carvedilol and placebo, you do see that there is a difference. Here's the atenolol study that I was talking about here. We are noticing a much higher percentage of these patients were achieving ROS. So the next one here were the human studies. So this one I thought was kind of very interesting. There's only 2. So they were looking at specifically a population of 49 post-MI patients. All right, so these patients are already known to have CAD, coronary artery disease. So what they used is their beta blocker strategy was the LSGB. For those is the left stellate ganglion blockade. They use esmolol or they use propanolol. And then in this study, they use landiolol. And what they were also seeing was that there is a significant reduction in VF episodes. And these were better short-term versus the long-term survival rate. What I think is kind of interesting here is that for those of you that know, I didn't know what a left stellate ganglion blockade was until I started reading this article, and I kind of looked into it. And I was like, what kind of block are they doing for VFib? So I kind of have a slide here about it. And so the idea about it is that, the stellate ganglion block, it basically, where the stellate ganglion is, it provides the majority of sympathetic innervation to the heart via the postganglionic fibers. So in MIs, they lead to partially the innervation of these fibers. And so it makes the heart very super sensitive to a catecholamine surge. So what they do is mostly anesthesiologists, and the one kind of video I watch on performing this is that they outline the landmarks like you see on the picture here. Some do this blind, some do this just, based on landmarks, or some do this via ultrasound. And what they do is they inject like about only the 5 to 7 milliliters, or either 0.25 or 0.5 milligrams of bupivacaine. And then they kind of could block this, and they've seen where patients who are in this refractory VFib electrical storm, that they have cessation of it, and they're essentially they were able to achieve ROS and kind of get them out of that rhythm. I thought that was kind of very interesting to see. In case you guys want to add this to your scope of practice, this would be something else you can kind of add to that in the ER possibly. We could do an in-service on it. But moving on, so kind of, the conclusion is that for that paper is that they're still lacking evidence on human trials. We only had the 2 studies that were there. So external validity. So can we apply this paper, the first paper and the second paper, to our patient population that we kind of deal with on an everyday basis, or depending on where you work? So I've seen, like I've told you guys before, I think definitely in the patient population, where I work mostly out of in Newark, which are, very sick patients who have very chronic ill diseases. Most of them already have risk factors for coronary artery disease and, dialysis. They do have, I think there would be some type of benefit here where, if the medics are calling you or you're working a code yourself and you see a persistent VFib, I do think it is reasonable for us to try to administer beta blockers prior to ending the code and pronouncing the patient, especially if you've already kind of defibrillated the patient 3, 4, or 5 times, and then you have another AED available and you now did double sequence, you change the vectors around and still in the kind of persistent VFib. I think, what's administering your beta blocker? I mean, why not? I mean, at that point in time, you're kind of going through all your H's and T's and trying to find reversible causes. I think this could be one of the things that we can use in practice. And I think it could be practiced, all throughout the system. I don't think it's that hard. I think our medics have metoprolol very widely available. I'm not sure if 5 milligrams IV is the dose, but I mean, that's a dose we've kind of been given IV. Maybe there's a way we can get another beta blocker on, kind of through the Pyxis that could be available for us. But I think it's something that's definitely worth trying. And then obviously there needs to be bigger studies that are being conducted so that we can see the true benefit to this, because ultimately the goal of this is not just to achieve ROS. Yes, ROS is great, but if someone's been down for over 30, 40, 50 minutes, an hour, what we worry about is the neurological outcome, which is the big kind of thing. We would like to see their survival and see what their neurological function is after they survive the cardiac arrest. And that is it. So now I'm going to open up the floor to discussion.
Yeah, great presentation. Anyone have experience giving beta blockers? I mean, I've given it multiple times. This is a patient who just is in refractory VFib. You basically exhausted all your other methods. And maybe that's a problem. Maybe that's one of the problems that we have, is that we're exhausting everything else and then we're going to this. Maybe we do it a little bit earlier, it'll have better effect. But I think that the evidence isn't ready for that yet. Anyone?
Greg, can you guys hear me? So
Yes,
yeah, go for it.
I think this was a great discussion. Thanks for kind of giving a good overview. So just a brief kind of thought process from my perspective. When you talk about the electrical storm and you talk about the VFib, it's always funny because any other ventricular dysrhythmia that we see across the board, we never give a catecholamine, right? We never give any type of adrenaline. So why is it that in VFib we're choosing to give epinephrine? Intuitively, and this never made sense to me. We've always given some other type of dysrhythmia, antidysrhythmic, but not really an epinephrine. So I've never seen someone give someone in VTAC, epinephrine. So why is it that in this ventricular dysrhythmia we choose to give epinephrine? We know that epinephrine in general, there's really no benefit, and really we've been trying to push for so long now to take epinephrine out of the algorithm for ALS, ACLS really. So that's one thing. The one thing I will say is that when we talk about, like when Navin pointed out, was that if you're going to have someone in cardiac arrest and you're giving them 3 epis, you're giving them catecholamine on catecholamine, you're giving them more epinephrine. So giving a beta blocker on the back end after giving 3 milligrams of epinephrine, you're kind of not really doing any benefit to the patient. I think ultimately, theoretically, what I think ultimately should happen is that we should take epinephrine out of the algorithm. If you have someone in VFib, the first line should be a beta blocker to actually counter the catecholamine surge that the patient is undergoing at this time. And so their endogenous catecholamine surge is what we're trying to go after, not the exogenous one that we're giving them and precipitating more dysrhythmia. So in my eyes, I think a beta blocker should be really the first course and first line of treatment in VFib. And ideally, that's who I would choose to do a trial on with like esmolol, and kind of give the beta blocker to. To your second point, giving metoprolol to a patient, versus esmolol, so it's very tricky. And the reason why is because you have someone in cardiac arrest. If you do get ROSC, you're going to have some level of stunned myocardium, some level of cardiogenic shock. When that happens, what you're going to end up having is a patient going to be hypotensive. And now you've given them a long-acting beta blocker on top of that. So the question now becomes is that you're going to end up chasing your tail by starting them on an epi drip or a levo drip. So being able to give someone a short-acting beta blocker, I think, is key because it allows you to, one, counter the one kind of catecholamine surge and electrical storm that they're undergoing, and then on the back end, being able to resuscitate them appropriately and not having that hypotensive state post-resuscitation. So, those are kind of my simple thoughts on just the algorithm of resuscitation when you talk about VFib and like beta blockers. I think there's a lot more to be done. Just like anything else we do in cardiac arrest, doing things earlier on, some of these interventions proves to be more of a benefit. Going 10 shocks in and then deciding to give esmolol, I think is somewhat of a moot point after I don't know how many epinephrines. I'm sure they gave many more than 3 epinephrines. They just had to meet the criteria of giving 3. So I would be very interested to see some study down the road where we're giving esmolol initially and seeing how the outcomes are. This is happening in Pittsburgh, and so this is happening in Pennsylvania. So there's a lot of places out there that are actually starting to do this trial, and they actually are using esmolol in the field. So there's going to be a lot of research that's going to be coming out on this because we do see some science in it, and we keep going back and trying to find some value in epinephrine. We keep doing studies on epinephrine, and we keep finding out that it's not inferior. So I think that we need to kind of get our heads around ventricular dysrhythmias and how to treat ventricular dysrhythmias appropriately and kind of move away from epinephrine. And maybe this may be a possibility, this short-acting beta blocker.
Tagore,
Yeah.
oh, sorry, go ahead, Nabil.
No, go.
So to do research like this where you could potentially use esmolol to start with instead of having to go through the typical ACLS protocol before switching to a beta blocker, would fundamentally you'd have to have that removed from the ACLS protocol to even consider doing the research where you're starting off with a beta blocker? Or right now what you're talking about in Pittsburgh and Pennsylvania, is that what they're doing?
Yeah, so one of the things that we talk about is when we look at ACLS protocol, at the very bottom of ACLS protocol, what does it say? Defer to medical judgment, physician judgment, and you kind of have to take your own kind of judgment into kind of account. So when you're deviating from ACLS, quote unquote, and so you're trying to figure out, is this the right thing to do? ACLS is years behind. If we try to go based on what's published in literature and we're not going by evidence-based medicine, then we're going to be in the ages, and so we need to kind of move ahead and say, what can we do differently without doing any adverse harm? Pittsburgh is doing it without giving epinephrine. So there have been some medics. It's interesting because where I've been on some scenes where we arrive on scene and basically BLS is on and they gave 2 or 3 shocks with an AED, and we come on scene and the patient's still in persistent VFib. So this is a patient where they look at me and they say, what can we do? And let's just give them 2.5 of low pressure and see what happens. And we don't even give epinephrine. So there have been scenarios where, yeah, you can give it, but I think the perfect scenario, honestly, is giving it before you're giving epinephrine. Can you give it after epinephrine? Sure. But what I've seen many times, and some of these last-ditch efforts that I've seen people giving, low pressure, on the back end of epinephrine, we inevitably see a change in rhythm, but it goes from VFib to asystole. And that's pretty much it. So you just block the patient, that's about it. So, it's anecdotally, when you see a resuscitation go on for greater than 30, 40 minutes, and you start giving these pressors, the outcomes are dismal.
Yeah, you brought up a couple points there. One of them is that we're not doing some of these therapies early enough. Giving epinephrine to someone in VFib, the reason is kind of like mute at that point. One of the reasons we give epi is to try and change the rhythm into something that's shockable. The patient's already in a shockable rhythm. So giving them, having a different pathway may make a difference. The way that I believe Pittsburgh is doing it is they're doing it as part of a protocol where, you have these criteria and you're going to follow this protocol. You can even go as far to apply for an IRB and make it into a true research project. Then you have to do public announcements. You have to basically do informed consent, but beforehand. And then you publish in newspapers, you take back-end articles, you do advertisements. but that's more on the research side. If you just change the protocol based on current evidence, that's just creating a statement, and this is the protocol that was approved by the medical board for that company itself, because ACLS is a guideline. There used to be a course called ACLS for the advanced provider. I don't know if that still exists. I was an instructor back in the day when I was a paramedic, but it went through some of these issues where it's like, once it's a guideline. You have to apply knowledge and the patient situation in order to make a decision, a clinical decision.
Yeah, I mean, ACLS is, again, remember, we're talking about ACLS is one level of care that you're going to provide. But, there's a course that I teach regularly from time to time at some paramedic professions. It's called ACLS Outside the Box. And you have to start thinking about a little bit outside the box about how you're going to resuscitate the patient and doing a focused resuscitation. If you look at like the ESMO study, one of the patients actually got calcium chloride and they got potassium chloride, which is like mind-boggling to me as to what was going on with this patient that they felt that they needed to give that. But sometimes you don't know what they're thinking and what treatment modality they're actually doing. But if you look at that first patient number 1, they got 10 shocks, and then they got potassium chloride and calcium chloride, which is interesting. So, and you never know. And this patient actually got ROSC, and they got sustained ROSC. So, I mean, again, sometimes you have to think outside the box and go outside the norm, and kind of see what can be more effective to the patient. Giving vasopressin versus epinephrine. Vasopressin actually isn't going to work on the heart so much, and so you're going to get that kind of systemic vascular resistance and try to increase the maps of the patient without actually having some added, significant effect, direct effect to the heart itself. So again, thinking a little bit outside the box sometimes can be more beneficial.
All right, great. Well, thank you everybody for having a good discussion about this. Just to kind of keep things moving, we're going to be switching over to Dr. Corey. I'm just going to make him a presenter really quick, who's going to be presenting the next article for us.
All right, can everyone hear me?
Yeah.
How's it going, everyone? My name is Phil, or Dr. Corey. I'm one of the second-year residents at Newark Beth Israel, currently on my EMS rotation. So the article I'm going to be talking about today is looking at pre-hospital ultrasound in trauma patients specifically. And the question that they're trying to answer is whether or not pre-hospital ultrasound in trauma patients has a use, and does it improve patient care and outcomes in these patients. So the specific reference is, it's an article called Ultrasound Use in the Pre-Hospital Setting for Trauma, and it's a large systematic review. So for the PICO questions for this, so the population here is just pre-hospital trauma patients. So the exclusion criteria, so they're looking at lots of different studies here. They're looking at studies that, or they're excluding studies that specifically are not specifically evaluating ultrasound use in pre-hospital trauma patients, articles that were duplicates of one another, letters to the editor, case reports, or any review articles. The main intervention is really just any ultrasound use in any pre-hospital trauma patient. So there's a very wide criteria that they're looking at in all of these studies. The comparison here really is a standard of care, which is just not using ultrasound in the pre-hospital trauma patient setting. The outcomes that they were trying to look for, whether there was an improved diagnosis or an impression, a treatment improvement, transport decisions that were made, like choosing to go to a specific facility based on their ultrasound findings, or if there's any changes in mortality for the patient. Ultimately, the author's conclusions was that the use of ultrasound in pre-hospital patients shows promise, but there's basically a large need for significant studies to be done, larger studies to establish its role and its usefulness. So although there's a good potential here, there really is no definitive answer on how useful it can be. So they just need to study this a lot further. For the quality checklist for a systematic review, So the first question that we really talk about is whether it's clinically relevant and is there established criterion standard. So it's definitely clinically relevant. In general, the use of ultrasound is growing throughout the field of EM, and I think medicine in general. As far as the pre-hospital, I know that at least in New Jersey and riding around with the medics, there's no ultrasounds on board with the paramedics, but the physicians that are doing their ride-alongs and responding to calls, I believe they have the butterfly, so that there is a potential for use here for ultrasound. There's no established criterion standard, so there's no set protocol for what type of ultrasound exam you're going to do on a trauma patient in the pre-hospital setting, but it's just something that could be looked at further. The search for studies was detailed and exhaustive. In this case, yes, they identified over 900 studies, and then they ultimately narrowed it down to about 16. We'll look at that flow chart next shortly. For the quality of the primary studies used to assess this, so they're looking for basic research bias, and what they did is they used this sign 50. It's basically a validated checklist. It's about 15 questions that they use, and it looks for bias analysis and observational studies and systematic reviews. So they were able to assess for bias on these studies. The assessment studies are reproducible. So I believe what they're kind of getting at here is, I mean, if you're able to review these articles yourself, then you can kind of assess them on your own, and that's reproducible. I think any person can kind of take the time to look and review each of these articles individually. As far as for low heterogeneity for estimates of sensitivity and specificity, so no, there's significant heterogeneity between all of these studies. So in total of the 16, 12 were prospective and observational, 3 were retrospective, 1 was a randomized controlled trial. There's a large geographic disparity between these. Only 5 of the 16 were in the US, which kind of points to our patient population. And then there's a huge variance in the ultrasound protocols used. Mainly they're using like FAST and EFAST, but there's a big variance. There's a few other protocols that they used in their studies. And then when they looked at the quality of the studies, only 8 of the 16 met acceptable quality, and none of them met high quality, minimizing the risk of bias and confounding. So there was no high quality studies as per their determination. And then as far as is this diagnostic accuracy sufficiently precise to improve upon existing clinical decision-making models? I don't think so, not yet, at least. I don't think we can adjust our clinical decision-making models yet, but with further research, we can. So as far as for how they identified their studies, so they did database search. They got about 907 studies. They removed 825. They had 825 after removing all the duplicates, and then they worked their way down to about 16 total. So 33 were assessed for eligibility, and then 17 of those they excluded based on the criteria you see there. So non-trauma, case reports, not pre-hospital, review studies, etc. So they came down to 16 from 907 total. Here's just kind of reviewing some of the major findings that they had. So here they were looking at all the different studies, mainly breaking it down by whether it was a physician doing the pre-hospital ultrasound or mixed practitioners, and that included nurses or medics as well as the physicians that were on site, and then what protocol that they used, and then the sensitivity, specificity, and then the positive and negative predictive values of their findings. So I highlighted a few findings here. So for the first one, so they looked at the EFAST protocol, and especially with EFAST and then PrEP, which is similar to basically doing a FAST exam. With these studies or these protocols, they're showing things that we kind of already know, like that there's a lower sensitivity, but a high specificity for these findings. As far as the fracture evaluation, what was impressive here is that there's a 100% sensitivity and a 94% specificity. So it seems like if you're trained well into looking for fracture evaluation, you can use that. But granted, a lot of these patients come in with significant deformities, and you can kind of identify the fracture just by your physical examination as well. As far as for the sensitivity here, so there's a 38% for pneumothorax, 31% for hemoperitoneum, and 46% in hemoperitoneum in the EFAST with mixed practitioners. As far as for pericardial fluid, when they were doing the EFAST with mixed practitioners, they found that there was a 99.6 specificity, and then a 0% for the sensitivity, but that's really just because they had no findings of pericardial fluid at all. So just looking at this overall, the ultrasound tests were going to be very specific, but not sensitive at all. Then further looking here, and this is basically determining the outcomes. So they're using the FAST protocol, FEAL, PLUS, and PrEP. So basically the FAST protocol we are all pretty familiar with. That's just our focused assessment. The PLUS is basically just a pre-hospital lung ultrasound, so really just looking for pulmonary edema in the lungs or pneumothorax. And then for fracture evaluation, again, like I said before, they're just looking for any signs of fracture, I guess, using just any deformity that they see or break in the line of the bone on the ultrasound. And here, with the impact of treatment decisions, so the lowest that they found was 10% had an impact on the treatment decisions, and then as high as 88%. So big variance here. And that was looking at, I guess, versus the PrEP versus the EFAS and echo. And I guess here they can say that you can't really come to a conclusion because there's such variance between the two of them. As far as for information to the hospital, it was as low as 1.6% were diverging information to the hospital, and then as high as maybe 52%. So again, large amount of variance. It can help you. You can set the hospital up by telling them that there's free abdominal fluid on your ultrasound exam, and then they know that the patient will likely have to go straight to the operating room, especially if they're hemodynamically unstable. So there's potential there. And then as far as for mode of transport, again, some significant variance, 1.6% for the mode of transport, and then as high as 32% for decision of mode of transport. And then choice of destination, it was, again, from as low as 0% to 27%. So I think ultimately it's not really showing that it's affecting their clinical decision making, at least not yet, for whether they're relaying more information to the hospital, changing their mode of transport, change destination. I think a lot of this is more guided based on your physical exam findings, your vital signs, and the mechanism of injury for the patient. And most of these are going to like a level 1 or level 2 trauma center anyways. So it's not really going to adjust where you're going specifically. One interesting study that I saw was included in this was they did a randomized trial of ultrasound guided peripheral nerve block in patients with basically dislocations or fractures. And then here it showed that they had actually significant improvement in their ability to reduce these fractures using nerve blocks rather than just analgesia. I thought that was interesting and something that could be possibly studied further for just a pre-hospital setting. This was done by physicians who were trained in pain management and regional anesthesia. So again, you would have to have significant training beforehand, but it could be something just to be studied further in the ER and just in the pre-hospital setting for stabilization of limb injuries. So for external validity and applicability, so how does this really affect my care? So as of now, no current effect, but it appears there is a role for pre-hospital ultrasound and trauma, and I think there's definitely a need for further research. Be hard to perform randomized controlled trials in these settings, but I think just further analysis and maybe developing specific protocols for certain situations could help assess this further. And I think overall the benefits for pre-hospital ultrasound definitely outweigh the risks. As long as you're a skilled provider that has experience with ultrasound and you're not delaying transport and care, spending 15, 20 minutes or something trying to get optimal views, rather than just using it as a quick assessment to look for free fluid in the abdomen, or any pneumothorax that you can treat on the patient and then just quickly transport them over to the hospital. I think these are all things that can be beneficial for the patient. So there's definitely utility. It can be useful in notifying a trauma center of positive findings. You can prepare the OR staff. If you let them know that you found a pneumothorax on your pre-hospital ultrasound and it's a tension pneumothorax, then you can just needle decompress there. If you were unsure based on your physical exam, and then the hospital can be set up for a chest tube right away when they get in there. Typically they do that anyways beforehand, but it could just increase the specificity of your findings. And then also it can be used for fracture dislocation diagnosis and successful reduction in the field, and especially with patients that have it like an unstable limb or concern for pulses. You can maybe do a quick nerve block and then try and set them up with the reduction as well. Unfortunately, none of these studies showed any impact on mortality, which I think is very important to know, whether pre-hospital ultrasound can help reduce mortality in these patients, and there is none out of these, these studies that they all looked at. So I think that'd be something very important to look at. So in conclusion, more studies need to be performed, but there is a potential for use. And then that's really all that I have for you here on this topic. So unfortunately, no major conclusions that can be drawn from this.
Thank you, Phil. Some of the things that you mentioned are actually fairly important. One of them is, the sensitivity and specificity. Basically meaning when you found something, it was very, very accurate. So if you found a pneumothorax, if you found blood in the abdomen or something, which is, everyone who's done ultrasound knows that when you find it, it's beautiful. But when you don't find something, it really doesn't mean anything. And that's one of the things that people have to worry about with some of these exams and some of these tests, that a negative finding doesn't mean anything, but a positive finding does. One of the other things, especially with pre-hospital ultrasound, specifically for trauma, is if you're going to the same trauma center, it's less utility than if this is going to make a different destination decision. Are you able to go to a community hospital versus going to a hospital that's a trauma center? Sometimes that's a big difference. Do I go left or do I go right? One hospital is 15 minutes to the left, the other hospital is 30 minutes to the right. And then, can this patient even fly? If you have someone with a pneumothorax, you know that you're going to go into the air. If you're going to intubate them, put them on positive pressure, that's going to turn into a tension pneumo very quickly. So making the decision that way, that can also make a big difference. Anyone else have anything to say about this?
I mean, Bill, thanks for the comments. We are seeing ultrasound used a lot more often now, even in the pre-hospital arena. We're seeing a lot of HAMs actually incorporating POCUS into their operational aspects of medical care. But there's a lot of EMS agencies now nationwide who have started to deploy point-of-care ultrasound within their practice. And certainly we see it in undifferentiated shortness of breath. We see it in cardiac arrest, where there is, some significant benefit. Now, when we talk about trauma, obviously, our goal is scoop and run, and we're trying to get the patient pretty much, to his destination. We talk about, like you mentioned, the change in mortality. I mean, when you have a trauma patient, and either a lot of times these patients are going to be, either they're DOA or they're going to decompensate within 5 to 10 minutes, or patients who make it past the 30-minute mark, their mortality, especially when truncal hemorrhage, increase significantly within 30 minutes, but then after that it decreases. So we know that. So if you've made it past the 30-minute mark, your mortality is going to be, much less. Now, patients with blood pressures greater than 90 systolic, their mortality is like 11%. Patients with, this is about, truncal trauma now we're talking about. Patients with blood pressures less than 90, their mortality is 46%. So there is, there are a subset of population of patients who are at risk, and it's at about 46%. And that number hasn't changed in 20 years. And the reason why is because we haven't been able to do many interventions for truncal hemorrhage. And so the FAST is really there for us to be able to augment and be able to change some management and care to be able to get the patient to the operating room sooner. And if we can expedite that a little bit faster, so much the better, especially when you're giving notification to your trauma team that this patient does have a positive FAST, and getting an OR ready and available is, huge. And so that's kind of where I feel like there's going to be a play. And remember also, a lot of you guys are EM residents, utility of a stethoscope in the pre-hospital arena is, in a trauma setting, forget about it. Imagine trying to auscultate where there's a diesel engine running, and you're trying to listen to lung sounds bilaterally. You needed POCUS. You need an ultrasound to be able to delineate whether there's pneumothorax. And again, like Navin mentioned, specificity, right? If you note that there is a pneumothorax, there's a pneumothorax, needle decompress. Again, you're giving good patient care when you can diagnose that and actually intervene on that, and before a patient decompensates, gets a tension pneumo. For the physician, down the road, obviously, some of the capabilities that we have as pre-hospital physicians is to deploy REBOA. So if I have a patient who's got, a FAST and they've got a borderline blood pressure, one of the things that you're going to be thinking about is, okay, is this a patient that's a potential candidate for REBOA? And do I need to, deploy REBOA in zone 1 for a patient who's now getting slightly hypotensive? And especially if you're waiting for HEMS to kind of come on scene and you see a positive FAST, this is a patient that I might be deploying a sheath in the femoral artery not so much the balloon, but the sheath, in the case that this patient now does decompensate and is refractory to TXA and whole blood, and now I need to deploy Reboa. So, these things will help us as practitioners in the field when we have some delay on scene, maybe waiting for HEMS. But certainly, the mantra is still, scoop and run and get to a trauma center so that way you can get definitive care.
Does anyone want to talk about the FAST exam or the EFAST real quick, like what views we're looking at and why they're important? Anybody?
I can talk about it, and I'll try and pull up an image of it too as well. That way I can kind of show the windows. But so the FAST exam itself, so you're looking at several different windows. You're looking at basically looking at the right upper quadrant of the abdomen, so between the kidney and the liver, and that's an area where blood can kind of collect. Then you're also looking between the spleen and the kidney, as well as above the spleen, and then that's another gutter in your abdomen, basically where abdominal fluid can collect in a trauma setting, likely blood. Then you're going to look in the lower abdomen as well. And then in this section, you can look basically at the bladder and see if there's any blood around the bladder, and then in the suprapubic gutter kind of down there. And then you'll also take a look at the heart. And then by looking at the heart, you can see if there's any pericardial fluid, so any free fluid around the heart as well. When you go to the EFAST, you're then extending this to the lungs. So you're just going to take a look at both sides of the lungs, usually at the apices, and then you're going to see from there if there is any sliding in the lungs, and that allows you to know if there's a pneumothorax. And it's very, very specific if you find no lung sliding, which would be evidence of a pneumothorax. So these are all beneficial. And then there's some extension of this as well with some of the other exams that they were doing here in the study, where they actually look at the aorta as well to look for signs of either an aortic dissection or a ruptured aortic aneurysm or anything else that could be a source of blood in the abdomen.
Excellent description. So for those of you who haven't done ultrasound before, the right upper quadrant is probably one of the most specific because when you're laying flat, that's where a lot of blood will collect. That's where you're going to see blood very quickly. In the upright patient, you're going to see them suprapubically, right along the bladder line. And especially for the lungs, you're able to see the lung sliding. So in the absence of lung sliding, or you even see a lung point, you know that you have a pneumothorax or blood in the lung, and that makes a big difference, especially if you're in the back of a rig or if you're in a helicopter. You can quickly see what's going on with the lungs without listening, because you can't hear anything over the diesel engine or helicopter rotors. And for our next person oh, that's a great image actually.
Yeah,
you want to put that back up while? Go ahead.
I actually wanted to comment something about the So a lot of people are talking about the drawback of ultrasound in trauma due to the fact that you have, when it's positive and you know what to do with it, but when it's negative, you can't rely on it because of such a relatively low sensitivity. However, there's a lot of places, specifically in Europe, are now using contrast enhanced ultrasound, and a few trauma centers in the US also that's their go-to modality specifically for pediatrics. And one such center is Delaware in the Christiana Care. I think that's their hospital system where they actually use contrast enhanced ultrasound. And the difference between contrast enhanced and regular ultrasound is that the ability to actually have a negative FAST and rely on it is much higher, meaning like the sensitivity of the exam is similar to a CT scan. And so it's extremely valuable. And if, obviously right now with the FAST and ultrasound, it's always a little difficult to get the buy-in from the surgeons. But when the time comes, I think we have great modality that could potentially be used in the pre-hospital setting with a great specificity, great sensitivity for trauma in pediatrics as well as adults, and can determine, how critical the patient is. Especially if you can, I think the sensitivity for contrast enhanced ultrasound is about like 80 to 90%. So again, like similar to the CT scan. And it's fairly easy administered. It's essentially just the bubbles that you push and wait about a minute or so and do the same fast exam. And you just see, you're able to see the filling defect of those bubbles, and that's your hollow viscous injury that you can detect with the contrast enhanced modality that you can have. So.
Marina, what is the sensitivity on on looking at like splenic grade or liver lacs that are like kind of 1 or 2 or 3 grade that really kind of haven't invaded past the capsule, or even like retroperitoneal bleeds? Anything on those with the contrast enhanced ultrasound?
Yeah, actually, they're used in Delaware already. So in the U.S., they're used their go-to modality for a patient that's a trauma patient is the contrast enhanced ultrasound, and the surgeons over there, they have the buy-in in it, and the sensitivity is again, there's papers that I can send you after that actually compares it to the CT scan, and it's very similar in sensitivity. So to me, I'm still, having had the ultrasound fellowship, I'm still dumbfounded why some places don't use ultrasound all the time. But this is something that's new and potentially very useful. There's just still a lot of hesitation of using this particular method in the U.S. due to there was a black box warning some 20 years ago for against the bubbles that the contrast material that's used, but multiple studies in China and in Europe have proven that there is no harm from the Lumison. That's essentially what people are using right now, that is used for the contrast as a material. And so, but this is the reason why it's a little bit slower in the U.S. market, because of this potential black box warning that was out before. So the medical legal aspect of it has kind of slowed the progression of this modality in the U.S.
All right, excellent.
I don't take my headphones out.
Well, we're gonna be moving on to the last article here by Dr. Rubin. I'm just gonna make her the presenter.
Yeah. Okay. All right. So here's my article. So my name is Marina, Dr. Rubin. I'm MD 425, and I'm one of the PEM fellows. Today I'll be presenting the pediatric article for you guys. It's a little difficult article for me because it's all based on mathematical analyses, but we'll get to that. So the article is factors affecting the course of resuscitation from cardiac arrest with pulses electrical activity in children and adolescents. So the clinical question for this particular research study was to find a correlation between factors affecting the CPR outcomes. It's a retrospective review of a prospectively logged resuscitations, and the way that they've done it, it's the location of this study is in CHOP, and the review is in Spain, I believe, that they've looked into it. But bottom line is that all of the pediatric patients that underwent in hospital cardiac arrest, all of their cardiac arrests were logged and then evaluated. This particular study was looking to kind of evaluate what happens between the pulseless electrical activity and the ROSC transition, and the effect of fixed factors like the age of the patient, their diagnosis, the reason for cardiac arrest, etc., and the variable factors such as like the CPR depth and the quality and so on and so forth. So a little bit of background. The prevalence of in-hospital pediatric cardiac arrest is more than 15,000 per year. But as we know, it's very difficult to study the pediatric population altogether, but the arrests are far and few between. And so there's very, very few studies assessing the factors affecting the course of the CPR. So design of the study, as I said before, it's a retrospective review of, again, like prospectively collected data. The timeline was 2006 to 2013, and all of these were in-hospital pediatric cardiac arrests. The way that they recorded all of everything that was happening is that their defibrillators recorded the chest compression depth and rate. They used the integrated accelerometer and the force detector. The ventilation rate was estimated based on the change of thoracic impedance, and the CPR process was annotated by two physicians, and they annotated it based off what was happening to the patient, and they kind of drew a time axis and kind of marked what was happening to the patient on this time axis. ROSC, just to kind of let you know about how they marked that. So ROSC was annotated when an organized EKG rhythm was observed for at least a minute. So the setting, as I told you before, it's in hospital, so it's not a pre-hospital study, but it's an in-hospital study, and it was in CHOP. That happened between 2006 and 2013. So it's and it's interesting because you have 67 from 2006 to 2013, you have 67 arrests that were documented in 59 patients. So I guess multiple patients coded multiple times. And just to kind of look closer on what those arrests were, generally speaking, it lasted for 14 minutes in median time, and the range was between 1 to 87 minutes of downtime. And then what they did with all of the information, they used Allen's additive regression model, estimating this cumulative regression of all of the coefficients that may have had some impact on outcomes of the CPR. To kind of deviate from our presentation when we describe our patient population that we looked at here, I just want to bring to your attention the description of the arrest itself to kind of see what is it that they were looking at and the demographics of the patients as well. It was, again, an in-hospital situation. The patient age for this group, because they said it was children and adolescents, the median patient age was 15 years, and the interquartile range was between 11 and 17 years of age of these patients. The median weight of the patient was 48 kilos, and again, the patients were ranging between 31 and 55 kilograms. 48% of the patients were female. They, in a different paper, they actually looked at the causes of the in-hospital arrest and the initial presenting rhythms for the same logged 67 arrests between 2006 and 2013 at CHOP, and they saw that 66% of these arrests were attributed to acute respiratory event. They also noted 52 transitions from PEA to ROSC in the 35 episodes, or 35 arrests, and then they also looked at 23 recurrences of the PEA from ROSC in 12 episodes of for these patients, and then 22 transitions from PEA to VFib or VTAC in 16 episodes of these arrests. They also noted that there were 27 episodes of sustained ROSC, and that would make 40% of these arrests. So why do we care? There's when I was reading this paper, I was trying to figure out, what am I going to do with this information? But this is actually very interesting. The most significant evaluation for the mathematical evaluation of this paper was what they looked at in the pulses PEA to ROSC transitions, and they found that there is a baseline intensity, which essentially is mathematically translated to a 7% probability to obtain ROSC per minute during ongoing CPR. And the interesting part that they found was that the deep chest compressions had an effect of 0.018 per centimeter depth per minute, meaning that if you were to perform your cardiopulmonary resuscitation in a way that you were compressing deeper, that would mean that you have you increase your probability of going from PEA to ROSC, and they were citing that it's 25% increased probability, and as such, they then went on to say that the other variables that they evaluated as well were not, they didn't find such a effect on the CPR, like any other CPR quality measures didn't have a similar outcome of bringing ROSC as our desired outcome closer and more plausible possible for if the deeper you perform the chest compression, that there is a higher probability of getting ROSC. So they also have found that after 7 minutes of CPR, that the chances of obtaining ROSC from PEA drops by 1.3% per minute. And why is that important? When you have a patient that you've been working on for half an hour, you may consider other modalities, such as, even possibly ECMO for the patient, as opposed to trying to get ROSC. So they said that they looked at after 7 minutes, if the deepening compressions will actually mitigate this decrease in probability of obtaining ROSC, and they said that it could, but again, after about 10 minutes, the probability of going from PA to ROSC was slim. Then they also looked at the recurrence rate from PEA to ROSC, and they said that the 20% recurrence chance for every minute of a patient who is already in ROSC. So you have to kind of also realize that once you resuscitating a patient and you finally got your pulses, and you may think you're done, but there is actually a high potential for going back into PEA. And then they also noted that deterioration to VFib or VTAC was very, very low for this patient population, and it's about 3%. So the authors concluded that deeper chest compressions favored PEA to ROSC transition, and they also concluded that after about 5 to 10 minutes of resuscitation, there is a low probability of ROSC, and that the clinician may consider a different modality like ECMO, as I said. So the strengths and weaknesses. So this study was a similar study to, this was a pediatric study, and they have a similar adult study. So this has similar outcomes. And in terms of weaknesses, this particular study was only evaluating what was noted down by the two physician observers, and also the objective measures, but they were not able to include in their evaluation the analysis of other things that may have been provided and done for the patient, such as like epinephrine or any other medical medicines that we're giving to the patient, and as such, this may be like a confounding factor. Given we have to think about how many I guess events. So it's only 67 events that we're looking at, and if we're not really evaluating what else is happening to the patient, we may be drawing conclusions that are just merely a not really a correlation, but just so happens that it just so happens, and it's just a false assumption that there is a correlation between, let's say, the depth of compression and the ROSC of the patient, and because we haven't looked at what other medications the patient has gotten. So these are this is just to kind of show you what these analyses look like. So this is the cumulative PA to ROSC transition intensity and versus the CPR in minutes. So as you see, you have kind of a linear progression, and the cumulative intensity kind of goes up the more that you have the CPR, and it goes to show the slope representing the intensity, and transition meaning like a conversion between the PEA and ROSC of 0.07. And this is the possible hypothetical relationship between the chest compression and depth. This is I guess this is a way of mathematicians looking at this type of study, which to me, this is honestly gibberish. But let's go back to our quality checklist. So I picked the quality checklist for observational study because this is what it was, even though it's not an observational study as to what happens to the patient themselves, but of kind of observation of the event and correlation of surrounding things that were happening to the patient, and CPR compression depth and compression quality. So the question, did the study address a clearly focused issue? This was a descriptive study, and they were trying to figure out, what are the things to kind of improve the outcome of the patient. So to me, it was a very broad question that they addressed, but in the end, they focused the question based on the PA to ROSC transition, and kind of focused just on a few things that may improve that probability. So I would say yes, they clearly focused their question. And then did the authors use an appropriate method to answer their question? Well, they used the mathematical regression models, and it seems like that's the way to assess all of the different factors that may fall into question, and to kind of figure out which is the one factor that causes you to have the desired outcome. So I think they did an appropriate evaluation of their question. Was the cohort recruited in an acceptable way? Well, the IRB was obtained, and it was just an observational study. So I would say yes. Next question, was the exposure accurately measured to minimize bias? Again, it's difficult to say, and I think the thought process about what else was happening to the patient may have an effect on the CPR and the outcome of the patient, and the fact that they were unable to evaluate that kind of increases the shortcoming of the study. But in terms of bias, I mean, it's all every single arrest was looked at, and every single arrest was in hospital arrest was evaluated. So there was no like recall bias or any other biases that we know. It's just that the way that I guess we'll come to some of the drawbacks, but generally speaking, I don't think that there were a lot of biases in the study. So I think yes, they minimized the bias. outcome. Again, I'm not sure how much these two questions are applicable to a observational and descriptive study. But again, like the fact that they looked at every single in hospital arrest and looked at as many possible variables, to me, I would think that the bias was minimized in exposure and outcome. And in terms of identifying all important confounding factors, I think their study mentions also the drawback of not being able to evaluate the medications administered to patients and how that affects the CPR and resuscitative efforts. So they do recognize that, and they do recommend that there would be a broader study where that could be evaluated. So yes, they have identified important confounding factors. In terms of follow-up of subjects, if it was complete enough, they just looked at at these arrests, and there's not much that you possibly need to look at in this particular study when you're trying to figure out whether or not you're going to go from PEA to ROSC. I think they've evaluated that, but then they also had an evaluation, I think at 90 minutes, to kind of see whether the patient reverted back to PEA. So they have kind of looked at all to timeline of your resuscitation, and I think it was fairly complete. Precision of the results, again, this is a descriptive study, so difficult to say. Do you believe the results? Well, again, I think I don't know. I have to leave this question up for discussion and to everyone else who deals with pre-hospital and arrests and more than me, but it seems like from what I know, quality CPR is something that will potentially get you the ROSC for the patient. But having said that, again, this is it's a group of patients that is not really studied well, and I guess there is no reason for me to not believe this result. So yes, I do believe the results. And can the results be applied to the local population? This is a good question, because CHOP, as everyone knows, is a very it's a place where you have all kinds of patients with very sick children there, with transplants and what have you. So in a general pediatric hospital, yes, you potentially can apply the results in the patients that come through your door and go into cardiac arrest in your hospital. But I'm not sure if this study is applicable for patients in the world, in the pre-hospital arena. Just because I feel like the patients at CHOP would be sicker, and also with the pathologists that you don't encounter very frequently in the field. And the last question, do the results of the study fit with other available evidence? So there was a mention of a similar study for the adults, and it seems like they have a similar outcome about chest compressions helping to get to your desired outcome, which is ROSC. So yes. And with this, I want to kind of open up for discussion.
Marina, thank you for that discussion. I agree with you. I mean, it's interesting because when you talk about, cardiac arrest and like chest compressions, especially, it's interesting that you say that changing the depth of compression or doing deeper compressions is going to make some different outcome. I mean, typically what we've been taught is to stay at a certain depth and not to really augment it to get ROSC, So, if we know that a certain depth is what's going to get us ROSC, then we should always do it that way. And that's what, high quality CPR is all about, and pit crew CPR is about. and having someone who's actually looking and you know, kind of when you're like running the resuscitation, that's one of your biggest goals, is to actually look to see, is high quality CPR being performed, and you know, is adequate depth compression being performed as well. So I mean, you know, I think changing it to do deeper, you know, may not be the case. And the second thing is, I agree, you know, the subset of patients that they're looking at CHOP, I mean, they have other significant comorbidities, and you know, the reasons why they're at CHOP is probably because they're getting obviously a high level of care, and so some of the patterns or some of the reasons why they may go into arrest, you know, especially in the hospital setting, may not particularly fit, you know, the bill of the pre-hospital pediatric arrest that we typically see, especially because a lot of the, you know, obviously the pure cause, mainly causes are respiratory in nature. But I appreciate the fact that, you know, the study does kind of go out, and this is obviously getting a robust pediatric N is difficult. So at least we can somewhat take some extrapolation out of it, and use some of the data to kind of at least give us some insight on pediatric arrest.
Yeah, I think just the whole pushing deeper, you know, push hard, push fast. That's the overall statement from the AHA, and it has to do with the fact that I think in maybe pediatric, maybe people are trying not to push too hard because they're much smaller. Even the adolescent ones are much smaller than what we're used to, and maybe we're just not pushing deep enough. Anyone else? Any comments on this paper? All right, I think with that, you know, this concludes this portion of the EMS Journal Club. You know, we are trying to bring back interesting cases. We're going to have a different format. So just email me any interesting cases you have, and we can review it. And then we're going to turn it more into a case presentation type of situation, not what it was before. The other thing is for the EMS fellows, we're going to be meeting up after this. I'm actually going to probably just do a group call. And I think the EM residents are finishing up their senior lecture. So thank you for joining us on this version of EMS Journal Club. The next one, I'm talking to the fellows for next block, and we'll have it probably in 2 to 3 weeks from now. All right, thank you.